Welcome to Vital Viewpoints on Healthcare, where we explore the policies, innovations, and the challenges shaping our healthcare system. I'm Jennifer Colamonaco, and today we have a truly exceptional guest, my colleague, Amy Bassano. Amy is a nationally recognized health policy expert with more than 20 years of experience driving transformative change in healthcare delivery and payment systems. She is currently the managing director of Medicare here at Health Management Associates, after what was a very impressive tenure at CMS as the deputy director for the Center for Medicare and Medicaid Innovation, as well as other roles within CMS. Throughout her career, Amy has been at the forefront of value-based care, spearheading models that have reshaped how we think about accountable care, bundled payments, specialty initiatives, and really how we are reshaping the future of the Medicare program. So today we will dive into some insights on Medicare policy, value-based payment reforms, and the future of healthcare innovation. Amy, thank you for being with us today.
Thank you, Jennifer. It's my pleasure.
So first, let's maybe level set. It is April 2025. The policy world changes by the day. So while normally in these conversations we, try to keep it higher level, you can't talk about Medicare right now without kind of talking about where we are in this moment. Lots of speculation about changes to come, what may or may not evolve as the 2025 budget reconciliation unfolds, and so forth. So, some of the things that we may talk about today may be irrelevant in 2 months. So we'll just tackle that as we get to it. But it certainly is a time of a lot of change. How are you advising clients right now in terms of what to look for?
Yeah, no, a lot happening. So we are spending a lot of time with clients thinking about what has happened in the past, what the first Trump administration, where their priorities were and the policies they were interested in, and then thinking what has happened since then, any subsequent policies, changes in legislation, where things may be going, what they want to see out of the next few years in Medicare policy or statutory changes, depending upon where they are at. So helping them think through sort of big picture issues, but then also very specific issues depending upon where they may be in the Medicare policy space, if it's drug pricing or provider payments or value based models. They're all in different places and different things. And of course, Medicare Advantage is the big issue across all of these with its continued growth and the continued number of beneficiaries choosing that as an option.
So, Medicare is always, it's the 800-pound gorilla of the federal government in terms of its size and scope and cost. We talk a lot about innovation in the program. We are especially now talking a lot about efficiency in the program. Those are probably two sides of the same coin, and certainly where you have a unique point of view there. We are also at a year where Medicare is about to turn 60. So, we're at kind of a moment of trying to figure out how to sustain the program moving forward. I feel like we're always trying to sustain the program. But in your experience at CMS and just working in and around Medicare for all of these years, why do you believe that innovation in Medicare can be so daunting and sometimes seemingly hard to achieve?
Starts with the Medicare law, the statute. There's places where it's very prescriptive and says a provider must be paid in this way, a beneficiary has to engage in that way. And so there's lots of rules there, and then CMS has filled in the blanks on that and through the regulatory process on how to try and change that, update that. But there isn't that much space to be able to innovate or change. And so it's always required acts of Congress to make major changes. And, going back to the 1980s when the DRGs were first implemented, CMS has become, or Medicare has been a leader, as you said, and a lot of those have had major impact on the healthcare system. But it's hard to make those incremental changes on a day by day, year by year basis, given the statutory changes, the regulatory requirements of the program. And so it's always a few steps behind on where care is, how the delivery system's working, the technology, the innovation of different types of services. And so it's just really hard to be able to do that. Plus, it's an enormous program. As you said, so much money and so many Medicare beneficiaries, and you need to design something that works across the country and for all the Medicare beneficiaries. So that makes it all the harder when you're trying to cover such a large swath of the economy and the American public.
Right. Yeah, our colleague Governor Mike Leavitt always says, if you want to change healthcare, you change Medicare, but that's no easy task, as you just pointed out, for probably intentional reasons, right? In terms of protecting access, you don't want it to, you don't want to be able to change it overnight, but sometimes you want to change it overnight. So in this environment where we're really thinking and talking a lot about efficiencies for a whole bunch of reasons, are there places where you think there are efficiencies to be gained?
Sure, there's lots of big picture ones and small ones. Just thinking about, you mentioned Medicare's coming up on its 60th birthday. In many ways, it's still designed for what healthcare was in the mid 1960s. You're just thinking about hospital versus, part A versus part B, the hospital side versus the provider side, and don't necessarily think about those the same way anymore, given the far less dependence on inpatient hospital stays people have, given how much the healthcare is delivered on the outpatient side. And so you still have those silos in place and lack of flexibility to really think across those particular programs. And so it's hard to how to be more efficient there, but then also thinking about how you can deliver particular services or things that a patient may need. It's so dependent upon, this is a Medicare covered service or this is not a Medicare covered service. And even if you see something where it's like, oh, it would make sense to have a more, say, robust transportation benefit so patients can get to their doctor's appointments, and so they keep them out of the hospital, it's harder to deliver that in an efficient way. Now, Medicare Advantage has more flexibility there and allows plans to develop benefit structures that are slightly different and a little bit more efficient to deliver the way the care, what the patients need. If they see a need for patient type of service, they can design a plan around that. But even still, that is not done in a real-time basis. It's, has to go through a whole bid process and a regulatory process on an annual basis. So it's not, to my earlier point, not very nimble and therefore not very efficient. And, you could think about ways to do that, but also at the same time, needing to protect the trust funds, the federal dollars that we're all paying into, but also the beneficiaries themselves. They need to be educated. They need to understand what their benefits are. And it probably is not be great for them, for those to be changing all of the time, for it's hard to keep up with track of all the different services that are offered and what they have. And so you want to make sure that they understand and they can have access to the services on a reasonable way without having to confuse them unnecessarily.
So you mentioned Medicare Advantage as kind of one area of innovation, right? They can put forth new ideas on the outside, and because they're sort of paid differently, can oftentimes bring new things to beneficiaries. Talk a little bit about value-based care. You worked in the Innovation Center, and for many years, the Innovation Center has put forth models, experiments, basically trying to figure out what are different ways we can change incentives. If you pay people differently, then do you get different outcomes? We have all, I think, the true believers of us that believe in value-based care, have been excited about many of those ideas, but yet, we do see that it hasn't moved the needle hugely in terms of healthcare spending or terms of outcomes. So maybe talk a little bit about your experience in sort of where value-based care has seen resistance, where it's been impactful and perhaps where, where it hasn't, or where there might be a new way to think about how to achieve some of these innovation objectives.
I think a lot about the term you used of incentives, of how are the incentives aligned or not aligned to want to move off of the traditional fee-for-service system. And for many that's still a pretty comfortable place. And it's not, the incentives are for them to continue to deliver more volume. The models have not been attractive enough to bring them into it. That being said, there are many, many providers, physicians, hospitals, health systems, others who have moved into value-based arrangements and have been successful. There's definitely been mixed results, and there's been a lot of learning over time, both on the part of CMS in terms of what an individual model should look like, but also how the multiple models can interact or intersect with each other and what that means for provider participation. And then also, how do you design more models to bring organizations or more providers in? There's a sense of that there needs to be more specialty models, because the specialists don't have as many opportunities as primary care physicians. And so, but then the more models you have, it leads to potentially more confusion and overlap. And so trying to find that right balance is something that is definitely much a work in progress. And you can see the evolution of over time of what the Innovation Center has done back from, almost 15 years ago, trying and testing and innovating and evolving over time as providers have gotten more comfortable with being involved in these value-based arrangements and taking on higher levels of risk. They've also spent a lot of time thinking about why are some providers not coming in. Sometimes it is because change is very hard and it takes resources. And so they've had some opportunities more recently to provide upfront payments for those resources or infrastructure. And so those are ways to get additional organizations into those models and finding, it's been a lot of time people talk about like glide paths or ramps to higher level of risk and trying to find that. It's a little bit of meeting where you are, but also giving you an extra little push or nudge to really come along, but really getting those incentives aligned. And they'll never be 100% value-based care for every particular service that Medicare pays for, but things like ACOs can really, when you're looking at total cost of care, can have a big impact. And then if you can then sort of connect in some specialty services over that, whether, whatever, oncology, cardiology, neurology, then that can really get to a true, more sustainable place if you can have more opportunities that are working and you can bring the providers in to want to do that. And then the beneficiaries are seeing better care, better services, better access. Hopefully they are, have someone 24/7 they can call so they don't end up in the ED on a Saturday night when they're not feeling well, or, don't need to go into the office when something's happened. They can just talk to a nurse or a doctor on the phone and, they can adjust the medications or send somebody out to the home to see what is going on there. So those are the things that are really, I think, successful in value-based care, but just making sure the incentives align and the opportunities are there for more organizations to come into that. And whether it be rural areas or other underserved areas or safety net providers, there's still a lot more work to do on this, but I think there's been, amazing progress.
So this idea of sort of models or pilots, it kind of presupposes that at some point you would roll it out, right? We're no longer testing. Now we're going to go ahead and scale what we've learned. It feels like there's been a lot of models and not a lot of scaling and rolling out to the core Medicare program. I could be completely wrong about that, and I'm sure I am wrong. But of all of these models and pilots, what can be at this point pushed out into the main program? And if not, sort of, if not much, then why not? I'm just struck by Part A, Part B, it grew up in a very siloed kind of a program. How much of it is sort of like massive transformation has to happen at the policy programmatic level in order for these pilots and so forth to roll out and scale into the program versus, we're building the right incentives to kind of overcome that?
2 points. The first being there's been an enormous success from models, meaning that so much learning has happened, both from the government's part and the participants' part, and sort of the general, people involved in value-based care in general have built better IT systems, have had better ways of engaging with beneficiaries. There's been, such growth there, and many of the models have built upon each other and learned new things. And so you don't want to lock into place what may have been the best design 5 years ago. And so that's why you see a lot of iteration, because they've learned more. There's more opportunities. You want to be more expansive. You want to be able to offer different types of services, different financing structures. And so we're not there yet in terms of this is the perfect version of it. And so you keep building. And also, there's a lot of different organizations or provider types that need to be involved. And so there's not a one size fits all solution. I'd also say, from like a very technical perspective, the Innovation Center Expansion Authority is very specific about what can be expanded, which sort of goes back to my earlier point about locking things in to a particular point in time. And that may not be the right decision. Even if a certain model's been successful, you may not want to expand that because you know there's better ways to do it, or you've gotten feedback from stakeholders and you need to test a new design. So I think the regular iteration on this is healthy and reasonable as long as the models continue to be successful. This is all assuming that they are saving money and the quality is improving. So I think it can go, that way, but also a point to the Medicare Shared Savings Program, which has been adopting a lot of the concepts that have been tested in some of the ACO models. And that's a permanent program. And so that continues to be there. I think there's a lot of thought about how do you continue to build that and have opportunities there, because when I was at the Innovation Center, we heard a lot, well, we like this idea, but we're concerned that this is a test for only a short period of time. And if we invest in all of this, where do we go next? And you see that now thinking about ACO REACH participants there, where do they go after ACO REACH? So it's a delicate balance of trying to test new and innovative things versus having a permanent program that can be more consistent and have, for organizations that want to do longer term planning past, a 5-year model, what does that be? So it sort of goes back to the balance and the general evolution of what's happening in innovation.
So it's less about scaling specific models that would achieve some measure of perfection, to your point, and more about identifying the levers that in each of the models that worked and kind of applying those in other ways.
Exactly. I think that's what the CMS has been learning over time. And certainly when I was there, I don't want to speak for them now on the way they're thinking about it, but from their recent some of their discussions they've had about models, that seems to be where they are going. Of course, scaling a model and meeting the expansion authority is always a wonderful thing, but that's not the only measure of success for a model or value-based care type of delivery of.
So in terms of the levers then, what's your sense of the levers that have and continue to be most fruitful in terms of, changing some of these incentives and overcoming some of these structural barriers?
So definitely financial. It starts with that, because giving either money up front that can be returned on, if you achieve the savings, or just being able to pull the money in different ways across parts A and B, these total cost of care types of models where you have this money and giving someone that to manage more effectively, efficiently, than just billing the claims and then having come in on the back end where no one's really thinking about all the spending that's happening on behalf of the beneficiary. So different financial approaches are important, but then also more flexibilities in the way the care is delivered. Telehealth was available in innovation center models long before COVID and long before it was more widely adopted, and still continues to be. They have these benefit enhancements and waiver authority to do this in the models, to waive, things that may get in the way in traditional fee-for-service to deliver the service differently. So that could be telehealth, more services in the home, more non-face-to-face services that care can be delivered in those ways. So thinking about how you do it differently, and that it's also not a one-size-fits-all solution, because an ACO that's dealing with a lot of rural patients may be different than an urban patient, or versus patients, who have different clinical conditions. And so giving the organizations who are taking on this risk that flexibility is really important, and the creativity in how they want to deliver those services. And so you see CMS continuing to offer more and different types of waivers of the Medicare payment rules to let the participating organizations, meet the needs of the patients that they're treating.
So when you talked about kind of giving the money up front, I mean, are we talking physicians? Who is the best kind of recipient of that? I mean, we think about you know, all of the work we do is sort of comes down to that physician-patient relationship, and what are the ways in which care is delivered in that interaction that can be, better outcomes, lower cost, more efficient, better experience, as the kind of the value definition leads us to. But how are physicians kind of faring in this environment? There it seems that the money oftentimes gets moved around, and the physicians, I mean, should they be the main recipient of these incentives and funds, and how are they kind of responding to that type of incentive change?
No, it is physicians, but it also is ACOs, which are really sort of collaborations of generally physician groups or hospitals, health systems coming together. And one of the reasons, or one of the things you need to do to be successful to manage that total cost of care, is a large number of Medicare beneficiaries, or ideally also that sort of same payment type of methodology for a majority of your patients in your practice, so that you have these incentives. You may hear a term multi-payer alignment, so that payers are all trying to have the same expectations, or at least aligned expectations, of how the physicians would be treating their patients and the type of care they would be delivering to them. So yes, you need sort of like it gets to be managing at a population level of significant number of beneficiaries to be able to take that, use that financial flexibility to manage their care, and think about across all of them, like, oh, we're going to develop a diabetes program, or managing congestive heart failure, or doing behavioral health integration. And so you need a significant number of beneficiaries in order to have a robust program like that, where you can see those returns on your investment.
Yeah, you mentioned multi-payer. I always felt like that was, if we truly get to kind of multi-payer initiatives, that's where physicians maybe have the greatest chance of success or embracing this, right? If they're doing things differently for one set of people than they are for another set of people, whether it works or not, that's just tough, right? So, do you feel optimistic that we've started to, move the needle with some of these ideas that are, whether by force or just because it's a good idea, like actually then showing up across populations?
I think there's a lot of interest in doing it, and other payers besides Medicare, want to be doing it as well. But it's, as with many things, it gets all into the details and on the implementation of it, of the commitment to do it, because other payers generally don't have, or there's no way they would have a population the size of Medicare fee-for-service beneficiaries. And so having enough patients in a particular area to do it, usually it's often done geographically, of, in this area, will all the payers come together? And so it also then gets into like unique dynamics of the payers in a particular market. So I think there's a lot of interest in doing it, but how it actually plays out in any given area, I would say there's been mixed results over time. But CMS, since the beginning of the Innovation Center, has had multi-payer primary care models, not across everywhere in the country. It was sort of, again, they were picking geographic areas and working with Medicaid and commercial payers and others to try and do that. I'd say the results are, have been mixed, given to sort of our earlier part of the conversation. There's no primary care model that has met the expansion authority or has been scaled in that way, but they continue to test different ways of incentivizing primary care transformation.
And you talked about specialty care and the specialists. What types of, are those following the same trajectory of like what we've learned from primary care, we're, transferring over to specialists, or has that really had to be a whole new set of learnings? I mean, we know specialists operate differently than primary care doctors, so there's that.
Yeah, it's been, there's always learnings a little bit from primary care. The areas that CMS has done the most sort of specialty work on outside of primary care would be oncology and nephrology, kidney care for, ESRD patients. But it's been hard for them to develop other models in that space, because how do you attribute the patient? How does a specialist, if you're seeing a neurologist, but you're probably also seeing a primary care doctor. So who has the responsibility there for that? And what are the services that are only the neurologist doing versus somebody else doing? And maybe you may even have 3 or 4 specialists who have a hand in some of this. And so there have been issues in terms of the design of these particular models of how do you attribute the patients? What are the services that are in or out? There's been talking about like episodes or shadow bundles or other things that are sort of built within an ACO model or a primary care model so that if a patient has an acute condition, where they need to see a particular specialist to have something managed, say after a cardiac condition, they would do that. The cardiologist could be responsible for managing for a certain point in time, and then it goes back to the primary care. There's a lot of joint management there. They have had in the orthopedic space, for hip and knee replacements, mandatory models there, originally episodic bundle models, but now they have some additional mandatory episode models coming online in the next year or so, where those are specialty focused a little bit more, but also hospital focused. Because again, it's a more of an acute situation where it's tied to having been in the hospital, and then what does that management post-hospitalization look like? So it's when you have something much more discrete, it's a little bit easier to carve that out for the specialist. But I know that all the specialties have different thoughts about what a model can look like in that space. And then the question becomes, how big is that? How expansive is it? What is the intervention? Could it be scaled if you to all of that specialists who are delivering that care, or is it just this really motivated group of innovators in a particular specialty who are doing something? So those are the questions that I would say CMS and the medical community have been trying to solve or think through for a decade plus now.
Do you think that we've sort of gone past the tipping point with I don't want to say with innovation because that's a general term, but with that healthcare is not how it used to be, right? We know that we're not treating patients the same way, we're not billing the same way, we're not all operating the same way. But oftentimes we're holding on to old reimbursement models or old kind of lines in the sand. It's been going on for as long as I've been in healthcare, which is a long time now. So do you feel like we're past a tipping point, or are we not quite there yet to where some of this stuff just starts to just be part of the ether of this, how we do it now, and we do it differently now?
Some places it definitely has, thinking about telehealth and how that's become just a sort of more normal part of the way as an option for receiving care. How the utilization plays out on Medicare beneficiaries is a little bit different, but that like people believe telehealth is here, or there's other types of, more services in the homes are becoming a more regular part of types of care that people are getting. I don't know. It's sort of hard to parse out like what's happening the healthcare system entirely, but also what's happening in Medicare, because one of I think the really interesting things is that will play out over the coming years is the continued growth of Medicare Advantage and the smaller number of beneficiaries in fee-for-service, and what will that mean for Medicare developing innovative programs, Medicare being the leader that we sort of talked about earlier on in this conversation. And so what will that mean? How much a role will Medicare Advantage be? But so much of the healthcare system and even Medicare Advantage payments are based upon a fee-for-service infrastructure. And so that seems to not be something that is not be as sustainable as it was before, just because if you have smaller and smaller number of people be getting paid under fee-for-service as opposed to other payment arrangements, both, I would say both in Medicare or in the commercial market as well.
So in terms of payments, you think we're kind of past the tipping point in terms of where the majority of people are being kind of reimbursed differently, majority of care?
I think so. There will always be fee for service, and there will always be situations where it's really warranted. Heart transplants or something that's so specific and so relatively rare that maybe that needs to be they will be paid in its own unique way, but sort of just traditional office visits or preventive services may be maybe that's sort of where we're in a different place on some of those, or rapidly approaching a sort of consistently different place for that.
If you had a magic wand, thinking about all of the different ways in which you have seen innovation encouraged, pushed, advanced, and all of the sort of the barriers that you've witnessed. So if you had a magic wand, how would you wield it? What is the one thing that you would fix to, I guess, perhaps enable innovation to take root more strongly than in ways that are productive to what we're trying to achieve?
Ooh, just one. That's hard. So I may take a little liberty on the one. I guess I would start with by saying that we've talked a lot about the providers during this conversation, and in particular physicians. They've had a rough time for decades now, literally, on consistent payment from fee for service, and they do not have an update like annual update like other providers get, and so the uncertainty in physician payment really drives a lot of the underlying issues, how to move to value, and how do you plan ahead, and how do you really commit to being in something for long term and change things if you feel like the ground is moving underneath you every year and you're going to have to fight for like 0% updates instead of cuts. And so fixing that, I think, could really fix a lot of issues in terms of incentivizing providers, say like, yes, I'm committed to Medicare, and they are going to be a good partner with me, and I'm willing to take a chance on trying something in this new model because at least I know some of the foundation is stable there. And I would say sort of related to that, and maybe it's really a second thing, is sort of the good partnership on both ends of having to have that stability across the models, and change is constant, but having a little bit more certainty of like, yes, I'm committing to this model and I'm going to be in it and I can stay in it for this period of time. But at the same time, it goes the government's way too. Yes, we know we're going to have X number of participants in this model and we can evaluate it because we're going to be partners in this for a period of time. And, on a year by year basis, it gets hard. I mean, there's certainly trade-offs on doing some of those things, but the sort of trust and partnership on both sides, I'd say, is having that good relationship is also really key for future success.
So the common theme of the two is sort of improving stability for physicians in the mix, both in terms of how they're
Yes.
paid and then the kind of agreements under which they're operating. Do you think it's because it has to go before Congress, or whereas the other updates are, I mean, is that the piece
Yeah.
that makes that so much more volatile?
It is. It's subject to congressional action and it is very expensive. And so in an environment where, more focus on federal budgets and what is sustainable, it will be hard. But, from a pure policy perspective on the physician payment side, I'd say that's what you need, recognizing, of course, that there's many other big picture issues that are coming to play here. But yes, it's a congressional, as I said earlier, the law is very specific on these topics, and CMS, the agency, does not have a lot of flexibility on many of those areas.
So, amidst all of this innovation opportunities, ideas for change, models, of all of this, what gives you the most hope in terms of the, long-term, not only stability, but success of the Medicare program?
Couple things. One, millions and millions of Americans depend upon this program, and it's generally very popular. So there will be an interest in, supporting and sustaining the program. But in terms of the value side of things, it's been really exciting to see over my time working in this area how the sort of innovation, to use that word again, but in the industry, about how businesses have come up to meet the needs and that have evolved as well, and that the sort of buy-in from the community to support this and seeing that when the incentives align, there are good business cases to be made, and that there are a lot of people who have invested heavily, both financially and business wise, in terms of making this be a success. So I think that this will continue to flourish, whether it be under fee-for-service programs, under Medicare Advantage type value-based arrangements, that this is really sort of here to stay. And there's so many great people working in this area, thinking different things, sort of whether it be the clinical approach, the IT, the beneficiary patient engagement aspect of it. So that is really exciting to see, and I think will continue to grow and sort of move on regardless. Obviously, having Medicare incentivize it and being a leader there, but there's still a lot of people thinking really interesting things about better ways to deliver care and take care of patients, and so that's exciting for me to see.
We all know there's information gaps in terms of just the healthcare system and how complex it is, and to kind of average voters or average beneficiaries, right? There's huge information gaps for a variety of reasons. But I'm always struck by there's such a negativity oftentimes with the private players. And so what you just said was that there is this entrepreneurial kind of spirit in the private sector that has really brought forth great innovation. And yet you see a lot of people resist or not quite understand and appreciate that. I always wonder why, like, how do you square that circle? I mean, it's such a big program, and it's the guarantee that it brings is so important to people, and obviously that raises issues. But do you think that they haven't experienced it in the same way, or why do you think sometimes that entrepreneurial ideas are perhaps don't get the credit that perhaps they deserve?
Well, it's hard. And there's a lot of organizations that have not been successful in this, especially when they think this is going to be easier. They don't understand the complexity of Medicare and dealing with the Medicare population, that it's not, or try to do things at scale. So it's a lot of hard work, and it takes time. There's no sort of overnight solutions or answers or get rich quick schemes. And so if you're looking for that, this is not
Right.
what it needs to be. But if you're willing to understand Medicare, understand the populations, I think there's opportunities there. And so it's not always the most exciting things, where it's like, if you're being an entrepreneur, maybe this is not the place that may be the first place you may think of. But I think there's a lot of opportunity and a lot of good work that has been done. But like I said, there's a lot of people who've tried it, and it's not for no fault of their own. This is just really hard. And to go back to the sort of moving ground underneath, laws change, rules change, COVID happens. It's really sort of an unstable place to be, or unpredictable. And it's hard to sometimes weather those storms, and people may not want to take that on.
Well, thank you so much for making time for this conversation. And again, as this year 2025 unfolds, there may be other twists and turns. We should expect other twists and turns that might change some of what we've talked about today. But I think there will always be a need to figure out how to do it better. There will always be a need for efficiency and innovation in delivering service to people at a vulnerable time in their lives. And so I think no matter what, the value of this work continues. So appreciate your time today.
Well, thanks for having me. It was nice to talk to you today. And look forward to continuing the conversation, as you say, with we are expecting a lot more to be happening in the Medicare space in the coming months.
This episode of Vital Viewpoints on Healthcare is sponsored by HMA Information Services. HMAIS is a subscription-based service that provides state-level data on publicly sponsored programs like Medicaid. From the latest managed care enrollment, market share, and financial performance data to up-to-date RFP calendars and state-by-state overviews, HMAIS has all the information you'll need to power your initiatives to success. This podcast was produced by myself, Jennifer Colomanico, along with Tiffany McKenzie, in collaboration with our guests. The content is the property of Health Management Associates.